Good evening. I am Dr. Kalyani Anbichelvan, advisor to Chennai campus. VIT is known for imparting highest level of knowledge transfer through faculty and industry experts. During COVID shutdown, I have organized a webinar on employability by Dr. MDV Kumarasamy, MD of a multinational company. It was well attended by a large number of students and faculty of VIT. Today's webinar is on robotic surgery. It comes under cyber physical system. Robots cannot be developed without the team of interdisciplinary engineers from mechanical, electronics, computer science, and electrical. VIT is very active in combining technology with healthcare. Chennai campus is very active in the field of robo, drones, and healthcare. For example, BTech in computer science with specialization in artificial intelligence and robotics have been launched in Chennai campus this academic year. Vision, guidance, and motivation of our Honorable Chancellor, sir, has enabled us to get IOE status. So let us strive to reach his next goal of entering into QS 200 ranking on these lines. I understand a team has filed for a patent of a robo which can fly, go on land, and go underwater. Our VIT team has filed a patent on drones for farming. Faculty has got a seed fund from VIT to work on robotics. Chairman of Lifeline Hospital was invited to address in IoT conclave during 2015. So our faculty have already worked on medical images for the research. Agency like NAC, NIRF gives due weightage in ranking for the knowledge transfer done by various experts. Government of India is advising engineering institutions to work on technology solutions for healthcare and villages. Robotics, artificial intelligence, big data, data mining, and virtualization are all technology that future generation of engineers have to be familiar with. Now even doctors have to be familiar with these terms. Robotic surgery has slowly but surely marched towards the limelight, so much so that a lot of complex oncology work is being done with medical robotics.
Kindly, can you excuse me from the meeting?
Can you excuse me for a minute, sir?
Good evening, sir. Chancellor, sir.
Good evening. 5 o'clock, 4:45 ஆரம்பிச்சிட்டீங்க.
4:45. அவங்க அந்த இன்ட்ரோடக்ஷனுக்காக கொஞ்சம் ஒரு 5 minutes முன்னாடி ஆரம்பிப்பாங்க.
எனக்கு 5 o'clock தான் போட்டாங்க.
ஆமா. அதான் நான் சொன்னேன் அவர் வரதுக்கு முன்னால ஆரம்பிச்சு.
So guest வந்துட்டாரா?
The beginning, sir. இல்ல அவங்க வெங்கடேஷ் சார் நீங்க வந்துட்டீங்க ஆரம்பிக்க சொன்னாங்க.
இல்ல கெஸ்ட்
ஆரம்பிக்கிறேன் சார்.
Yes. Has our guest come?
Guest has come, sir.
Okay, okay.
Shall I start the program, sir? Chancellor, sir, shall I start the program?
Yes, yes. If all the invited people have come, then we can start.
Venkatesh sir, நீங்க ஆரம்பிக்க சொல்லிட்டீங்க அதுக்குள்ள. Shall I start from the beginning, Venkatesh sir? Mr. Venkatesh?
No, you need not repeat.
Robotics, artificial intelligence, big data, data mining, and virtualization are all technology that future generation of engineers have to be familiar with. Now even doctors have to be familiar with these terms. Robotic surgery has slowly but surely marched towards the limelight. So much so that a lot of complex oncology work is being done with medical robotics. Robotic surgery is a new technology of minimally invasive surgery. In other words, it is the extension of the surgeon's hand. The operating field is more clear, will be magnified, and three-dimensional with precise images on screen. The robot translates the surgeon's movement into very precise movement in patient's body. The entire procedure is under surgeon's control. So the advantages are shorter hospital stay, mild post-operative pain, low incidence of wound infection, better cosmetic outcome, quick recovery time, and minimum blood loss. Nowadays, a lot of urological, orthopedic, cardiac, abdominal, head and neck surgeries are done using robots. More and more companies are getting into this sphere at present, and there is a huge potential for this tech in future. So it's imperative those engineers should get to know more about this, in which direction the medical sciences are advancing. The introduction of today's expert, Dr. Ananthakrishnan Sivaraman, will be done by Dr. Venkatesh, a senior professor of VIT Business School. He is also the Deputy Director of Academic Staff College. Dr. Venkatesh has got 3 decades of experience. He will be the moderator of today's session. May I request the Honorable Chancellor Sir to give the presidential address now. Thank you, sir.
Yeah. Madam, I'll give a very brief introduction of Dr. Ananthakrishnan sir before Chancellor gives his presidential address.
Yes, go ahead.
Yeah. Respected Chancellor sir, Pro Vice Chancellor, Advisor, dear colleagues, scholars, and students, it gives us great pleasure to welcome Dr. Ananthakrishnan Sivaraman to our midst today. As Dr. Kalyani Madam was indicating, robotic surgery is going to be the area for the future. We all know that robots are now being used increasingly for even performing complex operations like hysterectomy or fibroids, and robots do in fact a better job than even the most skillful surgeons. And also even medicines, the adjusting of dosage is being done by robots to clinical efficiency. So this is a very fascinating field. I'm not going to take much time. I would also love to listen to Dr. Ananthakrishnan like all of you. And with these few words, I request our Honorable Chancellor to give the presidential address.
Our chief guest of today, Dr. Ananthakrishnan, Dr. Kalyani, Dr. Venkatesh, other professors and students who have joined the program, very good evening to you. One of the leading doctors have agreed to be with us today and talk about robotic surgery. I find in the last more than 3 decades, medicine on one side and engineering technology, which used to be apart, have joined together or coming closer. That's how now we use engineering and technology, particularly technology, in the field of medicine. I remember we started this institute as Vellore Engineering College 35 years ago. And when it was given a university status, we changed our name from Vellore Engineering College to VIT. Once we became VIT, my slogan has been, both with the students and teachers, that from VIT to IIT, IIT to MIT. That has been my slogan for so many years. Now, Government of India has recognized VIT is one among the 20 institutions, 10 private and 10 government, as IOE institution of eminence. And now we are almost on par with the old 6 or 7 IITs. So now we have to march along and compete with MIT. We know MIT is an established, a reputed institution in USA. And we are encouraging our own students and teachers to go for research. MIT's innovation team is willing to collaborate with industry, academia, alumni, and working towards United Nations Sustainable Development Agenda 2030 in the areas of healthcare, energy, agriculture through disruptive technologies. As I told you, I have been always thinking of competing with MIT. It is time now we start focusing on providing technology for healthcare. Also, I urge faculty, research scholars, and students to focus on the same. I would like to cite some of the points done only by engineers. Remote healthcare using Internet of Things and artificial intelligence. Identification of cancer stage 1 using deep learning is the need of the hour in India. Blockchain can be used for secure transfer of medical records. Robots-assisted surgery is becoming popular in the last decennium, even though first robot-assisted surgery was done in 1985 itself. Robot-assisted surgery is very popular in US. VIT should explore partnership with them and start working. Recently, 2 students of Chennai campus, VIT, have worked for 6 months in the areas of robotics with the faculty in New Zealand who got research funds. VIT has appreciated them and extended financial support to the 2 students during the stay in New Zealand. When Dr. Kalyani, our advisor, wanted to arrange this session, I was happy and asked her to go ahead.
Thank you.
Robotic surgery
Thank you, sir.
may sound like something out of a science fiction movie, but it is quite real. Robots have been helping humans perform surgery for about 3 decades now. Surgeons use carefully designed robotic assistants as fantastic high-tech solutions for making procedures simpler, more accurate, and less distressing for patients. Millions of operations across the world are performed using Da Vinci robots, which hold surgical instruments and virtual aids with their many mechanical arms. These machines are specifically designed to reach areas the average surgeon can't access without making large incisions or leaving prevalent scars. For patients, robotic surgery advancements mean smaller incisions and scars, reduced risk of infection, less need for blood transfusions, faster recovery times, and reduced post-care discomfort, and shorter hospital stays. Robot-assisted procedures are growing even more popular as technology advances. And that means that more precise and efficient procedures with less and less patient discomfort. I'm happy, of course, the expert has come here and he is going to talk about robotic surgery to our students. We don't have medicine as a subject, but we have subjects like biotechnology, biomedical engineering, biomedical genetics, etc. And it will be very useful to our students and teachers. And on behalf of VIT, I welcome Dr. Ananthakrishnan for his magnanimously agreeing to our request. And I request him to enlighten us on the robotic surgery. Thank you very much.
Thank you very much, sir, for accepting our invite and coming over to VIT for this guest lecture or this webinar in spite of your hectic schedule. And we look forward to knowing more things, details about the recent advances in robotic surgery from you. Thank you.
Thank you so much, sir. In spite of your busy schedule, you have accepted this program. Sorry, we have started a little earlier because Venkatesh sir said you have already come. Extremely sorry for the inconvenience, sir.
Yeah. Good evening. Respected Chancellor, sir, Chancellor of VIT, Dr. Vishwanathan, sir. Thank you for this opportunity and allowing me to address your students. And I'm very glad that you're also part of this meeting. So it's a pleasure to be addressing VIT and its students. And I must thank all the senior faculty, including Dr. Venkatesh, and all the research scholars and students. And a special thanks to Mrs. Kalyani Anbichelvan for organizing this, this opportunity for me. So I shall share my screen now, and then we'll go ahead and give you an idea of what robotic surgery is. So sharing my screen. Am I audible?
Yes, yes.
Yes, okay. Thank you very much. I'm Dr. Ananth Sivaraman. I'm Director of Robotics in the Chennai Urology and Robotic Institute. So my goal here is to talk about robotic surgery. And before we go into robotic surgery, I want to give you an evolution of how robotics was in the millennia preceding the one that we are in now. And then slowly I'll talk about evolution of surgery per se and how technology has come into this field and the current status as well. So, so the history of robots dates back to several centuries ago. Now you can split it into three different eras. One is where we were imagining about robots. The next is the birth of the industrial robot. And then finally the birth of the robotic surgery era. So imagining robots, I think human imagination has never failed to impress anyone. So in ancient Greece in 270 BC, you had this water clock, which was the first iteration of a robot. And in 1495, Leonardo da Vinci introduced this mechanical knight, which is basically a functioning knight, completely automated. And it was one of the marvelous achievements of this thinker, Leonardo da Vinci. And the term robota actually means laborer, somebody or something that can continuously do what we want without getting tired, repeatedly doing all that we want. So it's a Czech word, Czechoslovakian word, robota, and it means laborer. And typically when we look at historical robots, we always talk about the MIT robot, the Puma, the Adept robot, and so on. And this was the MIT robot was one of the first robots. I was so happy when Dr. Vishwanathan sir said VIT to IIT and IIT to MIT. There's such a wonderful, inspiring goal for VIT, and I'm so glad to be a part of this now. So the MIT robot in 1959 demonstrated what was potentially possible in the era of robotics. 1959 it was. And then the next iteration, this is the robot. I'm sure all of you engineering students and research faculty would have seen this. It's a Puma robot. It's a programmable universal manipulation arm. Most of the car factories that you see in now, and most of the factories that have any degree of automation and robotics will now various newer generations of this arm have been introduced, doing much more complex tasks. But fundamentally, it was introduced in 1978. It is an industrial robot. And Adept is one of the largest North American companies manufacturing robots now. Several various iterations of robots have come up from this company. Now, slowly from the industrial area, they've come into the home arena. You've got robot pets like this, and second generation Sony robot, Aibo robot, and then Honda's Asimo robot, which is a technology demonstrator for a car manufacturing company. All of these just was a technology demonstrator to prove that robotics can come into mainstream. But more importantly, from a medical standpoint, medical applications, robotic arms, prosthetic arms, these are what are really useful when you look at how technology, as Sir said, technology and engineering and medicine, when they come together, this is what we can achieve. So what about the origins of the medical robot? It was actually an American government funded program, and it was by Stanford University late 1980s. And the original concept was to perform remote surgery in the battlefield. Now, for example, the American Army has about 1,000 soldiers and one doctor for every 1,000 soldiers. So they didn't want to expose this doctor to the battlefield. They didn't want him to get injured. So the idea was to keep the doctor 100 miles away, but still be able to operate on a soldier injured in the battlefield. So that was why remote surgery and robotic surgery was introduced by the American Army. But slowly it's come into mainstream medicine right now. So that was in 1980s. The first actual robotic surgery was done in 2000. And from there was no looking back. Now I'm going to give you several robots that have come and gone and not really come into mainstream, but this was the basis of which how things started. So you had the medical robots now transporting drugs, and this was way back some 20, 30 years ago, but it didn't really become mainstream. But now in this COVID era, the pandemic, now we want something like this, primarily to go into wards where COVID patients are and deliver drugs to them, without actually exposing a staff or a doctor unnecessarily when they don't need to go. So this is something that may have a comeback in the future. So, and the next was the rounding robot. A similar principle, a robot with a screen would go into a patient's room where the doctor would be speaking to the patient on the screen, somewhat like a teleconsultation that you hear now. But the patients didn't like it. They really wanted a doctor to come and see them. They really wanted a doctor to come and examine them and then give them advice. So this also was went out of the window when we talk about medical robots. And then early surgical robots were used in neurosurgery, where cranium with fixed landmarks, you can do some navigation and 3D imaging. But again, it didn't really take off. So that was a small introduction of how robots evolved and how they touched the medical field. But how did surgery per se evolve? So the statue that you see here is of Sushruta. And we can rightfully be proud that as Indians, he was one of the master surgeons more than 1,500 years ago. So 1,500 BC. So imagine such a tall figure, Indian surgeon, who wrote the text on surgery, right? So next we come to evolution of surgery. We talk about surgery. This is in France. It's in 1600s. And you see the type of instruments they were using, the tiny instruments. And you see one surgeon performing the surgery, and there's a patient lying down, and there are two people holding the patient. You know why? We did not have anesthesia back then. They couldn't control pain for the patient. And the patient might run away if we did surgery on a patient with pain. So we had to have 2 people holding the surgeon, or holding the patient. So the instruments were available back then, but we didn't have anesthesia. And slowly anesthesia was introduced. This again was 1800s, again Massachusetts, and where ether anesthesia was introduced. So then we could perform surgery with tiny instruments on patients without pain. But the patients were still dying. And the reason we're dying was because of infection. So we didn't have a way of controlling infection back then. And then we have this gentleman, Lister, introduction of carbolic acid, and then the aseptic technique, and then slowly antibiotics came into the picture. So this one, again, one more advancement. So we had the instruments, then we had anesthesia, and then we could perform surgery without patients dying because of infection. So that started the era of surgery per se. Then you had the era of big surgeons and big surgeries. Then you could open the tummy, put in the kidney, take out the kidney. So this is a transplant being performed here. And so that era, the sky was the limit. So surgeons would open the tummy, open the chest, do any kind of surgery they wanted. But you have to think of one thing. Patients, when they come to us, already sick, you don't want to be putting a big cut on their abdomen or the tummy or the chest to make them all right. So we were saving lives definitely as surgeons, but not the quality of life. Imagine putting such a big incision and operating on a patient. That wasn't the right thing to do. So slowly what we needed was minimizing incisions. And the era's 1980s was the era of laparoscopy. Tiny, tiny incisions, and we could operate inside the abdomen. And this was the era of laparoscopy, where you had reduced blood loss, fewer complications, shorter hospital stay, faster recovery, less scarring, and less risk of infection. So as the era of laparoscopy progressed, we also realized there was limitations with laparoscopy. And what was the limitation of laparoscopy? Number one was loss of depth perception. So in any country, if somebody had only one eye, they would not be given a license to drive. And the reason was you need binocular vision for depth perception. So laparoscopy wasn't able to provide that. Of late, you have 3D laparoscopes, but predominantly you didn't have laparoscopes that give you a 3D vision. So inside the abdomen was 3-dimensional environment. But when you looked at a TV, it was a 2-dimensional environment. So again, that was a limitation. Hand tremor. Anybody holding a long instrument or a stick in their hand will see a tremor at the end of the stick. Again, similar to laparoscopy. You are holding long instruments in your hand, that will give you tremor. And imagine having tremor when you're operating. It had decreased range of motion, and the precision wasn't great and ergonomically uncomfortable. So what we needed was, we needed the comfort of open surgery without, the comfort of open surgery, but still in a minimally invasive way. So what we wanted was the ease of operating in open surgery, but tiny incisions. And this is where robotic surgery came into the picture. So it's a combination of what you can achieve with open surgery, but with minimal invasiveness of robotic surgery, with laparoscopy. So improved visualization, improved instrument control, dexterity, and superior ergonomics, where the surgeon sits down and operates. That was the key advantages of robotic surgery. So if you looked at the camera that we use in robotic surgery, it's a binocular vision. So you will be able to see in 3 dimensions. So that's very important as a surgeon for me to operate. I want to be able to see exactly where the tumor is, how far I need to go, what is the depth I need to cut. All this is important as a surgeon. The instruments were as small as laparoscopy or even smaller, and wide range of movements. Now in laparoscopy, you had only 4 degrees. You had to go in and out, left and right, up and down. But in robotics, you have 7 degrees of freedom of movement, and it came with a wrist. So if you ask me when I operate, which is the most important part of my hand to help me operate, is the wrist. So this robot allows us to use the wrist when we're operating. That's one of the key advantages. And I can move my instrument 360 degrees or more, but the human hand cannot move that much. So that's again one of the key advantages of wrist. The wrist and finger movements are mimicked by the robot. And a lot of people ask me this question. So you see there, you see the tiny instrumentation that we have. It's a diamond tip forceps that you're seeing right now. A lot of patients ask me, sir, the word robot, does it mean that the robot is operating on its own? Or as a surgeon, are you operating? The answer to that question is very simple. Currently, with the technology that we have, it is only the surgeon who is operating. The robot cannot operate on its own. It cannot even move a millimeter without the surgeon operating. Maybe in the next 20, 30 years, things might change. But as it stands now, though it is called robot, it is a surgeon that is operating. I'll give you an example. If you see this video, what we do outside happens exactly inside the abdomen. It is not something, so I have to put my head in the console for us to operate. Otherwise, the robot will not work. So every movement that is done outside with this joystick-like instrument from the surgeon console and the three-dimensional environment can be replicated. So what I see inside is 3D effects, and what I do outside will be exactly transmitted inside with benefits. So there's something called motion scaling as well, which means if I move 1 millimeter outside, it can move 3 millimeters inside. And if I move 3 millimeters inside, I can program it to move 1 millimeter inside as well. So again, the motion scaling is there. Tremor filtration. So if my hands are shaking outside, the instruments will not shake inside. So that again is one of the advantages of using robotic surgery. So there's only one company in the world that is currently making and marketing robots, but there are several companies in the fray. They're coming with newer versions every year. So the one company is called Intuitive Surgical. It's an American company. And the robot that they sell is called the Da Vinci Surgical System. So this is one of the most widely used robots in the world. So this is an example of how we dock the robot. So this is the hospital that I trained in the US. So if you look at this picture that you're seeing right now, the head of the patient is towards us, the leg of the patient is away from us, and we've already put tiny ports in the abdomen of the patient, and this is how we attach the robot. And the arms of the robot will be attached to the patient by this method. So once the arms are attached, then we put the camera and the robotic instruments so that we'll be able to operate inside. So the surgeon sits about 10, 15 feet away from the patient. You don't need to sit next to the patient at all. But what is important is robotic surgery cannot be done alone. I need a team. I need my assistant to be sitting next to the patient. I need him to put these instruments like you see that's being done right now. And there you see the three-dimensional camera being put inside the patient's abdomen as well. So this sort of surgery is very good for certain types of surgery, especially cancer surgery, where precision is of very high importance. So there you see the instruments going inside the patient's abdomen, and this is how we will operate, right? So once it's fixed, after we put the ports inside, it takes about 2 minutes for us to put all the instruments inside, and we can go ahead and operate. So why is robotic surgery so important to urologists? Why is it so important to the surgical oncology field as well? So one of the key areas in which we use robotic surgery is the prostate. The prostate is a small organ. I'll show you where it is. One second, sorry. So the prostate is a small organ below the bladder. And if you take any robot, for instance, the majority of surgery that the robot does will be for the prostate. So it's one of the commonest surgeries that we do, especially prostate cancer. So if you look at the mortality rates across Asia for prostate cancer is very low. But if you looked at mortality to incidence, then we are very high, which means the likelihood of us Indians dying because of prostate cancer is very high, right? So the first robotic surgery was introduced in the year 2000. 15 years ago, PSA was approved in America, and slowly it started trickling down to various parts of the world. And by the year 2000, everybody was getting it done in their master health checkups. So we were diagnosing a lot of prostate cancer, and cancer that was curable, and cancer that could be cured by robotic surgery. Now, if you take any cancer anywhere in the body, the key point is, if the cancer is within that organ, it is usually curable. If you take kidney cancer, if it's only in the kidney, you can cure it. If it's spread to other parts of the body, it's difficult to cure. Similarly, prostate cancer, if it is only in that organ, is 100% curable by performing surgery. So again, because we had a lot of patients that we could cure, and then because we had an instrument that afforded the potential for that cure in a minimally invasive way, robotic surgery just took off with doing prostate cancer surgery. So I'll give you another example as to why it was important to do the prostate. Because deep down in the pelvis, this yellow organ that you see here, these are the kidneys, this is the bladder, and the small yellow organ is a gland that produces the semen. This particular entity is deep down in the pelvis. If you do an open surgery, if you put your hand on the prostate, you'll be able to feel it but not see it, because it's way deep down in the pelvis, right? So if you see it, you will not be able to feel it. So that is one of the key advantages. I hope all of you are okay to see a surgical video picture, right? So some of my friends who went to engineering college said they didn't want to see blood and they became engineers. So, but I think in the future, we are all going to be one field, which is a field that is helping people improve better, lead better lives. So I think we should all be able to watch this. So this is an advantage of using robotics. You see us operate, this area is deep down in the pelvis. If you ask surgeons who do this as an open surgeon, they'll tell you that they'll not be able to see this area because it's under the pubic bone. So, but in robotic surgery, I can see very clearly, and I can suture it as well as I can suture in open surgery. So this is something that is very easy for us to do in robotic surgery. If you look at the instruments, how fluid the movements are, it is exactly mimicking what we do in open surgery. Again, now you see, we're putting the needle. Where I'm putting the needle is called the notch of the prostate. It's about a millimetric area behind the prostate. And for us to see, I'm using a 30-degree lens, looking behind that area, putting the needle exactly in that millimetric spot and bringing it out in this millimetric spot. So again, the precision, because in laparoscope, it is 10 times magnified. But in a robot, in laparoscope, it's 4 times magnified. In a robot, it is 10 times magnified. So the magnification is much, much higher. And because we are seeing in 3D and we have depth perception, again, this step is much easier for us to do. So I'll quickly go on to the next points. So a lot of people ask, does robot improve the longevity of a patient? That is an important point to answer. So it's not that the robot is doing any surgery differently. The surgery is already being done as an open surgery. But what we're doing in robotics is we're increasing the quality of life for the patient. We're not putting big incisions. So how does the robot improve outcomes? So here is a picture that's interesting that'll be interesting to a lot of you. It's called the trifecta. If anybody's gone for horse racing, if you're able to predict which horse comes first, second, and third, that's called predicting the trifecta. So in cancer, the trifecta is cancer control, and especially when we're talking about prostate, is urinary continence and sexual function. So all this is very important. So if you look at, this is the prostate, and this is the neurovascular bundle. Neurovascular bundle is the nerve bundle that goes to the male organ, that is the penis. So when we operate on the prostate, there is a potential for these nerves to get damaged, and the sexual function as well as the urinary leak rates of the patient can increase. So what it is that we're trying to achieve here is remove the cancer without decreasing the patient's quality of life. I think that's the key point that we have to remember here, right? Imagine a 50-year-old person has cancer prostate, And if we operate on the patient and say after 50, you will not be able to have sexual intercourse, that's not an acceptable point. 20 years ago, when I was studying in Madras Medical College, the only concept was take out the cancer. Nobody was worried about the quality of life. But in 2020, if we just take out the cancer without looking at the quality of life of the patient, I don't think that's an acceptable proposition. So that is where robotic surgery comes in. We not only save the life, but we also save the quality of life of the patient. So again, a small video. I hope this is okay with you. It's a little bit more bloody. So this is an important point. This is the point where robotic surgery plays a part. So these instruments are tiny instruments. The nerves are even tinier. They're millimetric nerves and non-myelinated nerves, very tenuous nerves. They're like hair follicles. And if you look at this, you have to preserve these nerves to give the patient a good quality of life. So if you go a millimeter to the right, you will get into cancer, and that defeats the purpose of doing the surgery. If you go a millimeter to the left, you will damage the nerves and the patient will not have a good quality of life. So again, precision is very important. That is why this 10 times magnification, the pneumoperitoneum, the 7 degrees of freedom, and the vision again makes a huge difference in the outcomes that we can give for our patients. That is where robotic surgery scores over conventional open surgery or laparoscopic surgery, or for that matter, any technology at present used for treating prostate cancer. So you see this plane that I've separated, the nerves are on the left side and the prostate cancer is on the right side. And all I need to do is separate the blood vessels going only into the prostate. Again, it's a bit of a slide, and I'm sorry I'm making a lot of you engineering graduates watch this. But the main point that I'd like to emphasize is, if you look at this area, this is the tiny blood vessels that go into the prostate. We've saved the main neurovascular bundle. And this is one of the key steps in robotic surgery, where we save the entities that need to be saved and we take out the entities that need to be taken out. Again, one of the key steps in robotic surgery is preserving vital structures. So in terms of operating room time, in terms of blood loss, in terms of complications, in terms of positive surgical margins, which is a surrogate marker for the quality of surgery, in terms of continence, in terms of sexual function, the robot definitely scores over conventional open surgery. And this has been proved more than 10 years ago. Again, what I'm trying to imply here is that robotic surgery, though it looks modern, is not a technology that's not, it's new. It's been there from the year 2000. And currently all over the world, there are more than 8,000 to 10,000 robots that are being sold, that have already been sold. But in India, the number that is being sold is only 70 robots. Again, we're lagging behind the rest of the world in this. So when you compare surgery to other modalities, again, I'm going to quickly skip a couple of these slides. The surgery scores over radiation and other technology. But the point I'm trying to make here is the bar is being raised. Every year, every day, with robotic surgery, what we're able to achieve is better quality of life for the patients. Not only prostate, in renal surgery. And I'll give you a quick example of renal surgery. I hope this is again a small video where we cut a small tube. This tube is about 4 to 5 millimeters in thickness, and we're able to cut that tube and attach it to the rest of the organ. Again, it's a bit too bloody. I'll skip to the next video. So this is one slide that is a very favorite slide of mine, right? Previously, 10 years ago, when somebody had kidney cancer, they would take out the entire kidney. But now we only take out the tumor and save the kidney. Again, that's a very, very important point. So when I go through the rest of the slides, I'm going to tell you where all technology has come into our field of robotic surgery and our field of medicine. And I hope this inspires a lot of the students and the research faculty working at VIT to improve our lives as doctors far better. So there you go. So this is some of the technology that we use during surgery. So we have a robotic drop-in ultrasound. So imagine a tumor. This is a small, I'll give you another video. There you go. So this tumor here that you see here is a tumor that is within the kidney. Now, when you see the kidney, when I take out, if I'm doing open surgery or if I see the kidney, I will not be able to see the tumor. But the CT scan can see the tumor. But when I'm looking at it with my open eye, I will not be able to see the tumor. So I need a device that tells me where exactly the tumor is. And when we're dealing with the kidneys, every time the heart pumps, 1/5 of the blood that is being pumped goes into the kidney. So it's a very vascular organ. So when we operate on the kidney, we have to stop some of the blood supply, but we cannot stop the blood supply forever. It's a maximum 25 minutes is the time within which we have to completely remove the tumor. And that's why we need a ultrasound. So if you see this ultrasound that you just saw in this picture, it helps us identify exactly where the tumor is. And we cut out the tumor. So 10 years ago, 5 years ago, this patient, if it had come to any urologist, they would completely remove the kidney. But now we're able to remove only the tumor and save the kidney. That is one of the key advantages of robotic surgery, where we do it in a minimally invasive way, this partial nephrectomy. This step where we completely cut out the tumor is called partial nephrectomy. I'll quickly go on to a step where you completely close the rest of the kidney. So this is what we use, a dedicated robotic ultrasound transducer that goes into the body, and then we'll be able to identify where the tumor is. I can place the ultrasound probe on top of the kidney and then know exactly where the tumor is and cut out the tumor. So there's very little chance of us making a mistake when we're operating, right? So again, this is another video where you see us operate with an ultrasound guidance. So this is where I'm doing a prostate surgery after radiation. So if you look at it, I've got 3-dimension vision on the top screen, and I've got the ultrasound telling me where exactly to cut as well. So I've got a 4th dimension telling me how deep to cut, how much to cut, and how far we need to go inside. Again, one other way in which technology helps us when we're operating. So advantages: decreased blood loss, lower pain levels, faster recovery, shorter hospital stay, smaller incisions, lower complications, and better outcomes. These are the key points or advantages of robotic surgery. And again, for the surgeon, when we're sitting and operating, it's a far more superior, ergonomically superior way of operating on patients. So the technology works, because in America there are 5,000 robots, and every major hospital in the US has a robot, right? So it won't be like that if it didn't work, this technology. But what about India? How should India react to this? If we concentrate as doctors and engineers, if we just concentrate on the technology part of it and we don't touch the human part of it, we will be missing the point. So how should India react to this technology? So if this book, I would urge you to read this book by Everett Rogers called Diffusion of Innovations. So the early innovators are the guys who introduce it. Early adopters is currently, when you look at robotic surgery, America has been an early adopter. Early majority, Europe has been an early majority, and we fall under the late majority. India is in the late majority, because for a country with 330 million people, that is USA, they've got 5,000 or more robots. And with a country of 1.3 crore people in India, we've got 70 robots. So if we don't adopt this technology, we will be the late majority or even the laggards. So I think India as a whole should embrace this technology. And that is where key institutions like VIT come into the picture. So, because the limitation has been the company that is producing the robot, because there's only one company in the world at present doing it. If a lot of companies are in the fray, the cost, the technology will become more widespread. So learning curve. Again, we should talk about learning curve as well. So it's not something that can be easily performed. It's not like if I have a robot, then the outcomes become better. Every complex procedure that we do has a learning curve. And there's a learning curve in laparoscopy, there's a learning curve in open surgery, and similarly, there's a learning curve in robotic surgery. So imagine if I had the same car that Michael Schumacher, the Formula One racer had, do you think I'll be as fast as him? And the short answer is no. So it's not only the instrument, that is the racing car or the robot, it is also the surgeon's training that makes the difference. So you have to be a good surgeon in order to give good outcomes. A bad surgeon cannot use the robot and give good outcomes. That is impossible. So your training should be good. You have to breach your learning curve, and then only you'll probably give good outcomes to your patients. So, and it's all been documented. So for decreasing blood loss is 50 cases, operation time is 120 cases, and decreasing margins is 150 cases, and so on, right? So again, important point that I'd like to make, the robot cannot make an average surgeon a good surgeon. It's very important to undergo a structured training program to breach your learning curve and give good outcomes. A key question that everybody asks is, what is the cost? How much does the robot cost? So the robot currently in India, when you buy a new robot, it is somewhere between 15 to 18 crores. And every year you have to pay at least about 1 crore or 90 lakhs for annual maintenance contract. So again, it's expensive technology. It's not cheap. But how can we provide it at an affordable cost, right? We have to maintain quality and quantity. And the only way to achieve it is centers of excellence that do only robotic surgery. So we have to have enough volumes to achieve what we want to do, quality and quantity. So we need to scale up and adopt a multidisciplinary approach to provide a center of excellence. So if you ask me as a surgeon, if we do not touch the masses, the technology can never be called as successful. So India has got 1.3 billion people, the world has got 6.7 billion people. And if we don't adapt enough to give technology to the masses, I don't think we can call ourselves successful, even though we are performing the latest cutting edge surgeries, or the engineers are producing latest cutting edge robots. So always we have to think how we can touch the masses with the technology that we have. So is it only used in urology? No, other fields are also using it. General surgery, colorectal, hepatobiliary, that is liver surgery, ENT surgery, and cardiothoracic surgery as well. But predominantly it's being done with urological surgery. So I told you at the beginning, there's only one company that's producing the robot. We now have other companies also in the fray. So the Medtronics, again, a major medical device manufacturer, and they've come up with the Hugo robot, which is again similar principles, where the surgeon sits in a separate console and operates. And then you have the British company, CMR Surgical. They've come out with their own robot as well. These are all in various degrees of pricing, they've introduced it. But the technology is more or less similar. The idea is providing good outcomes for cancer care, and at the same time minimizing the incisions. So before I finish, there's a small video that I'd like to play. Again, this video came out some years ago, but this is what eventually will happen. If you look at this, the surgeon walking into a surgical console. Currently, we're sitting on a surgical console and operating, but here again, they can, this idea behind this is what is potentially possible. I currently sit about 10 to 15 feet away from the patient that I operate, but the distance can be longer. I can sit 1 kilometer, 2 kilometers, and it's transcontinental surgery has also been tried. But the biggest limitation has been the signal lag. If we have a signal lag of 400 milliseconds, then we can, less than 400 milliseconds, we can operate. But if the signal lag is more than 400 milliseconds, then it's detrimental for surgery. But hopefully people talk about this 5G technology and dedicated lines and so on. And if that happens, then me sitting 10, 15 away can be 10, 15 kilometers or even 100, 150 kilometers. So, but then again, all this is possible potentially in the future. A lot of things have to change. The mindset of the patients have to change as well. Imagine telling the patient, the doctor is about 100 kilometers away, but he'll still operate on you. A lot of our patients will not agree, but maybe in future, things will change. But I need power cord, please. Maybe in future, things will change very quickly. So again, thank you very much for this opportunity. I must thank the staff and management of VIT. And it's been such a pleasure addressing all of you, especially, and thank you for the Chancellor for sitting through the entire talk. And I'm very thankful for this. And I'm happy to answer any questions. So I wanted to give you a brief idea and overview of what robotic surgery is. But specifically, if you have questions regarding how the technology has matured over the years and how we are changing lives of patients, happy to answer. I'm sure you have a lot of students who asked questions. So, Dr. Venkatesh, happy to answer.
Yeah. Thank you, Dr. Ananthakrishnan, for the illuminating presentation. And okay, can we have 4 or 5 questions, please?
Absolutely.
Students?
Absolutely.
Yeah, over to students. Yeah, one by one, you can ask questions. Yeah, the first question.
Venkatesh sir, can I say a word?
Yeah.
Sir, I'm Dr. Gopinath from VIT Chennai. I'm an associate professor. See, my family is one family which has been benefited through this robotic surgery. And you have performed a surgery for my father at the age of 84 and is very fine now, sir.
Mr. Venkatesh.
Yes, sir. Yes.
I have a question with the doctor.
Please,
yes,
sir.
Yes, sir. Yes, sir.
Dr. Ananth, where are the hospitals where we use robots in India?
So there are about 70 hospitals in total in India that have the robots. In Chennai, if you take, there are about 3 hospitals. One is our hospital, Chennai Urology and Robotic Institute. Then the Apollo group has a robot. I used to be the director of robotic surgery at Apollo before moving on to my own hospital here. And if you take India, it's major corporate hospitals that have the robots installed in them.
Oh, okay. Any of the government hospital, do they have?
The All India Institute in Delhi has the robot. And again, the Pondicherry Jipmer, I think, has recently bought a robot. So the government hospitals have not gone on to the robotic bandwagon very quickly. Though All India Institute in Delhi initially started it, but not a lot of government hospitals have taken it. In fact, at present in Tamil Nadu, no government hospital has got a robot. But again, when you look at being a health secretary or a health minister, when you look at it, do you want to treat 10 people with prostate cancer or 10,000 people with hernias? So as a government setting budgets, you'd rather want more people to be treated for more common ailments rather than ailments that specifically need very high investment. But then again, recently I heard that our Tamil Nadu government is also going to invest in a robot.
Thank you, doctor. I see this after a long time. I have seen a heart operation being performed in CMC hospital about 40 years ago. One of the doctors asked me to see from above. I think this is the second time I see. Very interesting. I thank you.
Thank you very much, sir. Thank you for staying for the talk.
And Dr. Mr. Venkatesh, I am Dr. Chokkalingam.
Yes,
Can you make one
doctor.
comment?
Yes. Yeah, yes, doctor. Yeah.
Yes.
And my brother chairman, Chancellor Viswanathan's best friend is our Parasite Anbalagan.
Yes, sir.
And his grandson only Ananthakrishnan.
Yes, sir. Yeah. Kalyani madam told. Yeah.
He was my student.
Okay.
A long time back. Best credit for any teacher will be when I see my student excel Chokkalingam. and gives me happiness. That is what
Yes, sir.
Ananthakrishnan gives me great happiness.
Yes, sir.
Very
Yes.
confident. Very soon, our chancellor see that he makes his own robo, comes in the name of VIT robo. It is possible.
Yeah.
Is
One
Ananthakrishnan,
citizen.
Dr. Chokalingam,
Yes, sir.
Ananthakrishnan, Dr. Manavalli's son?
Yes, Manamalli's son, sir.
Oh, yes.
Anand's cousin.
Oh.
Another thing is, what I want to say, now Ananthakrishnan was telling about engineering, medicine like that. Now, the collaboration of bioengineering is the term. Without engineers, no doctors can operate, especially cardiologists, everything engineering. Stenting, balloon, pacemaker, artificial, everything. If there are no engineers, I think now our chancellor is having both medical and engineering colleges. I think in our country, in our Southeast Asia, he will be a pioneer in creating his own instruments that will be a leading one for the globe. Only one question, Ananthakrishnan.
Yes,
What
sir.
about any mortality or morbidity in robotic surgery? Any risk of doing that one?
There's no specific extra mortality because we are doing robotic surgery. In fact, in even major procedures, when we do it with robotic surgery, the mortality risk comes down because the tissue invasiveness of the surgery decreases. So again, when you compare it to open surgery, there is no extra risk. In fact, I would say the risk decreases when we're doing robotic surgery compared to open surgery or laparoscopy.
What is the percentage, Ananthakrishnan? Today, if you do...
It depends not on the technique that is used, sir. It depends more on the patient's condition. So as a technique, it doesn't make a difference in mortality rates. It only depends on which type of patients that we are operating on. Obviously, a patient who's got high cardiac risk or... Hello, can you hear me?
Yes, we can.
Obviously, a patient who has got a higher cardiac risk or higher pulmonology risk and so on, has a higher mortality rate. Specifically, robotic surgery does not increase or decrease the risk of a patient's mortality or morbidity for any particular surgery. So it's more the patient factor rather than the surgical factor.
I think we all must give a very big hand for Chancellor and Kalyani for this excellent program, and my congratulations for Ananthakrishnan for this excellent exposition. I appreciate Ananthakrishnan.
Thank you, sir.
Please continue your journey. I'm very proud about you all. My best wishes to our Chancellor and his students. Thank you very much, sir.
Yeah, Dr. Anant, there are
Yes.
two more questions.
Please.
One by Dr. Sudarshan and another by our student, Mr. Maktoum Ali. Huh?
Sure. Yes.
Please. Yeah.
Respected doctor, good evening. Good evening to everyone present here. My main question is, doctor, all this advancement in robotic surgery equipments in the upcoming years, wouldn't it create a huge form of unemployment of surgeons due to AI being in major progress over the upcoming years?
I think that's a very interesting question, especially coming from an engineering student. So the way to look at it is robots, or even when you talk about robots getting into the manufacturing field, robots getting into the surgical field, I always think that once they get into a particular field, other avenues open up for people in the various manufacturing sectors or something like that. So they always have to adapt. If they don't adapt, then there's a chance of them losing their job. That is what we see again and again in industry, even in our own medical fraternity. You know, people were talking about general surgery, for instance. One of the commonest surgeries that was done those days was for acid reflux. So that surgery used to be done left, right, and center. If you looked at any operating list per se, right? The number of surgeries done for acid problems was literally 50%. But then some medicines called proton pump inhibitors came into the picture. And then that surgery was completely gone out of the window. So nobody does that surgery anymore. Again, cardiothoracic surgeons, Dr. Chokalingam will allude to this, Previously, they were all doing a large number of CABG surgeries. But then once angioplasty came into the picture, the number of CABG surgeries totally came down. So, but it didn't reduce the the workload for the doctors. It didn't reduce the number of cardiothoracic surgeons. They all went into other fields and other aspects. So again, the way to look at it is every advancement has the potential for improving a patient's quality of life or people's quality of life. But the persons whose job they feel threatened have to adapt and move on to other fields. That's how I look at it. I don't think we can stop technology or knowledge from completely permeating to the rest of the world. That's a very good question, though.
So, thank you. I am Dr. Sudarshanam.
Yes, sir.
I have a question. In the sense, what are the different types of or quality of the robo, like which you use for the surgery? Do you buy from foreign countries, or because normally we have different types, right? Quality varies.
Currently, there is only one surgical robot that is being sold in the field of in the surgical field at present. There are some robots available for orthopedics and neurosurgery, but they're not mainstream. The main robot available is from Intuitive Surgical. That is an American company that has produced the robot. And for the last 10 years, they've been, or last 20 years, they're the only company that's been selling the robots. In the next few years, if you looked at my last two slides, other companies like Medtronics, Johnson & Johnson, and CMR Surgical have come out with their own robots. One is a British company, the other two are American companies, and they have the potential to create some competition for this monopoly that we have in the robotic field at present.
And one more thing is, how about the connectivity? As you said, about 10, 15 feet, and use any like network or Wi-Fi?
Currently, the connectivity is wired, but like you said, the potential is there for wireless connectivity. And especially with the 5G coming into the picture, there is a potential for this distance to increase as well.
Okay, thank you.
Yes, sir. I have a question for you.
Yes, please.
Is the risk element lesser in robotic surgery when compared to conventional surgery, sir?
Yeah, the way to look at it is the conventional surgery produces more trauma to the tissues compared to robotic surgery. So definitely in that context, you have a reduced risk that the patients recover faster, shorter hospital stay, and so on. But per se, because of this technique, there is no increased risk or grossly decreased risk.
But another question I have in the same sense, like, how about the security? In the sense somebody hacks it. People also say, right, the pacemaker, somebody can hack it. How do you face all those security challenges, cyber security challenges?
So at present, all these robots are directly connected to via the internet to the mother company in America, but they can operate without that connection being there as well. So Intuitive Surgical has put several methods in place for the hacking not to happen, but again, it's possibility. So always when I look at these things, I always look for a motive. Well, who would want to hack a surgical robot during a procedure? I think more important question is, will a robot fail during an operative procedure? Again, it has happened. So, in a 1 in 1 million cases or 1 in 100,000 cases, there's a potential for the robot not to work when we're operating. So the surgeon should be skilled enough to perform the surgery in laparoscopy or in open surgery. So that's very important. So if the robot fails, and it has happened, then the surgeon should be competent enough to perform the surgery in conventional methods. That's all that matters.
Okay, thank you.
Doctor, one MBA student wants to know, how long will it take for the common people to get access to robotic surgery?
Currently, it is possible.
Currently
people from the year 2020, from the month October 2020, I think most of the insurance companies have agreed to cover robotic surgery. So the common people can afford robotic surgery from this year onwards, I think. So it should be possible.
Sir, can you hear me?
Yes, please.
Sir, I'm Radhika. I have a question. You said that the robotic surgery has no effect on improving or decreasing the mortality rate. in a country like India, where we have a human wealth, where we have so much of human wealth, and why do we need the robotic surgery? Because anyways, we have abundant doctors, and this robotic surgery is not going to improve the longevity of human life. So why do we need this invasion of robotic surgery, sir? How do you see this?
When I say it doesn't improve the longevity of a human life, I mean it doesn't improve it more than conventional surgery, but it definitely improves other parameters like the quality of life of the patient, like the recovery of the patient. Imagine when I say it improves the quality of life, when you do conventional open surgery, imagine the patient and his caregiver staying in the hospital for 7 to 10 days. But in robotic surgery, they'll both be back to home in 24 to 36 hours. So the time spent in hospital, the loss of work for the patient, the loss of work for the caregiver, all that makes a difference. So it's not only, if you just look at one particular aspect of it, one facet of it, it may look like it, but you have to look at it in an overall context, and then it will make complete sense to you. So nobody wants just to be alive. They want to be alive as well as having excellent quality of life. That is where the robot comes into the picture.
Yes, sir.
Yeah,
Sir.
I have another question. Since how do you build artificial intelligence? Say, for example, without doctor, can you do a easy job or a small job?
That's a very nice question, Dr. Darshan, because currently most of the companies in the robotic field are going into this artificial intelligence. So all of the companies every day come to me and say, sir, we'd like your surgical videos, because they want to annotate the surgical videos. And the first step towards artificial intelligence is, when we are operating, the robot can tell us whether we're going to make a mistake or not. So that is the first step in which artificial intelligence comes into surgery. Then imagine 20, 30 years from now, if we pre-program the robot and with simulation, if we make the robot, if we do the surgery beforehand, and the robot can do the surgery at a later date. Again, all of these things are currently being attempted and tried, but they're not yet in the mainstream. It will take some years, at least a decade from now, for it to come into the mainstream. So artificial intelligence, big data, the video is the big data for all these companies now. So all this expected in the next 10 years.
Okay, thank you.
So good evening,
Hello,
sir.
good evening, sir.
I'm Dr. Vijay Lakshmi, sociology faculty from VIT Chennai campus. I have a basic question, actually. You said that in India, there are few hospitals, but as far as US and other countries like China and all, there are more hospitals with robotics treatment. But I have a basic question that, how about patients' comfort? When a doctor comes to me, checks me, touch me, there my response itself is, first of all, as a person, it is different. When a robot comes me, touch me and make all the treatment on me, how about a patient's response, comfort, as far as comfort is concerned?
Very nice question, especially apt for a sociology professor to ask this. When we see the patient every day, I see the patient, I touch the patient, and only when the patient goes into the operating room, after anesthesia, does the robot come into the picture. So the patient, in effect, would never see a robot. They would only see me. And then after surgery also, they see me. So during surgery only, the robot is there. And during that time, the patient is under anesthesia. I hope that answers your question.
Yes,
so,
yes.
Don't worry.
Because when it comes to India, that is much more a difficult task. If at all our people see robots, and the feeling that his robo is going to treat me, that itself will be a first a taboo or a restriction for me to go into the hospital. Even here
now,
we have gender differences. Still, we have not come out of it. Beyond
even
technology.
now, whenever I talk about robotic, when I say the word robot, they talk about the movie Endiran.
Yeah. Yeah.
Thank you, sir.
Sir, I have one question regarding, hello?
Yes, please.
Sir, this is Dr. Vetrivel, and I work in terms of engineering perspective, like data acquisition, putting a different sensor in the patient body, and putting what do you call something like data acquisition in terms of network, and taking it to the gateway, and doing some health analytics. And after the analytics, we are back to the controlled output to the again to the patient. So is there any standard? Because with respect to general data communication, we have several standards. with respect to medical critical applications, is there a standard got evolved and which is applicable to country like India?
So, to be honest, for the answer to this question should probably come from a biomedical engineer. But I'll tell you what currently when I was in the US, we wanted to have some fiducials as to where the instruments are when we're operating, because we wanted to build a simulator. But the IP for this belongs to Intuitive, the company that produces the robot. So I don't think you can get that out from them at present because it's still patented. But to be honest, your question needs to be answered by a biomedical engineer, not me.
So, hello, sir. Good evening.
Dr. Kalyani, can you close?
I would like to say a few words.
I have, sorry to disturb. I have a
Sir,
last
Chancellor, sir.
Yes.
Your vision, guidance, and motivation have enabled us to get IOU status. Let us strive, sir, to reach your next goal of entering into QS 200 ranking on these lines. Thank you very much, sir, we are really honored by your stay with us. In spite of your busy schedule, you are able to spend time with us. Thank you, sir.
Thank you. Thank you, Dr. Ananthakrishnan.
Thank you, sir. I must also thank you, and such an inspiring word that VIT to IIT, IL to MIT. So very, very happy to hear that. Thank you so much, sir. Thank you for this opportunity.
Yeah. Thank you, Chancellor, sir. Thank you, Dr. Anand. Thank you, Kalyani Madam, Dr. Chokalingam, all my colleagues, fellow scholars and students for the very good participation today. Thank you.